without further ado, I'd like to invite up to the stage Dr. Helen Barr from the University of Nottingham. So we're now moving into session 1 of the day, enabling people with CF to live longer, healthier lives. And Helen's going to talk to us about delivering clinical trials in a new era of CF. Welcome, Helen.
Thank you very much, Gwyneth, for the kind introduction and for the invitation to speak today. Now, Gwyneth has set the scene really nicely today, and we've heard some really nice basic science from Robert today. I'm an associate professor at the University of Nottingham. I'm UKCF clinical trial lead, and I'm honorary consultant at Nottingham here today. Now, I don't have any slides on the underground, I'm afraid. Here are my disclosures. So today we're going to cover an overview of the clinical trials network and how that really has adapted to the changes in cystic fibrosis. We're also going to go through a little bit about the drug delivery pipeline and community voices in clinical trials. So the UK has responded to the rollout of CTFR modulators, and we set up CTAP, Clinical Trials Accelerator Platform, initially to help support these trials, but also we integrate that with supporting public and patient involvement and business development as well. We've already seen this slide, but I would just like to highlight here the amount of work and impact the CF teams and many of you in the audience and at home have helped into delivering these trials. And we can see this year alone, we've had over 1,300 people who've enrolled in a CTAP supported study, over 1,000 adults and nearly 300 children. And more than 3/4 of these trials have exceeded their recruitment target, and the average retention rate is 98%. So that really does show that the network has been really working well to deliver these clinical trials. So if we move now to look at the therapeutic approaches, you will note that there's quite a lot of diversity in the therapeutic approaches in the portfolio, and there's a mixture of investigator-led and commercial trials. We can see here there is restoring CTFR function, genetic therapies, and GI and anti-infectives that we've talked about before. But what we've really changed in the last few years is there's been an increased focus on early phase trials, and that is particularly in the genetic therapy phase. There's been integration of digital technologies and home monitoring, and of course we have had ACE-CF, which is looking at home monitoring for pulmonary exacerbations. We've embraced electronic recruitment, virtual recruitment, and non-medicinal interventions as well, such as yoga CF. And we've even had a trial within the registry, including CF Storm. So let's look a little bit about the drug development pipeline, and this was downloaded from the Cystic Fibrosis Foundation last week. And we're all familiar with many of these vertex therapies, which are now available to the vast majority of people with cystic fibrosis, the latest being Alyftrek, which was approved by NICE and NHS England in July and is licensed for those 6 years and over who have at least one CFTR gene that will respond to therapy. But there is other companies that are also working in the early phase sectors here. For instance, up below we can see Sionna Therapeutics, who have developed a nucleotide binding domain stabilizers, and they have several complementary modulators which are being tested in the early phase and are currently in phase 2A, actively recruiting in the US. But of course, we saw those lovely graphs from Robert looking at the increase in lung function and reduction in sweat chloride. And we are really looking very closely at reduction in sweat chloride. And we have actually had to adapt our outcome measures to more sensitive markers of lung function. And one of these is lung clearance index. And whilst it has been used quite a lot in the paediatric population, there is need for many of the adult teams to upskill and retain their competencies in this area. And of course, this has led to difference in changes in the trial design, and we need more sensitive outcome measures and patient-reported outcomes, and community involvement is really important in this environment. So what about those who aren't able to benefit from CTFR modulators at the minute? Well, there are the genetic therapies that are currently running in the UK, and these are gene agnostic, so they can help potentially benefit anyone independent of their CTFR gene status. And these are trials of nebulized therapies which aim to restore CFTR function in the lung. And we have 3 here that Robert has discussed, and they use a variety of viral and non-viral vectors to deliver either mRNA or DNA to the respiratory epithelium. But what's been important in the delivery of these trials is there is a finite population that they've been tested due to strict inclusion and exclusion criteria. And what we've had to do is ensure we link the registry data with the potentially eligible patients. And to do that, it's been important that we use patient identification centres, which we've been championing here at CTAP, and also regional and regional networks as well. And this is going to be increasingly important. And for those of you who haven't had a chance to look at Emily's entourage, I would encourage you to look and click on the website. It really is a great resource for people with cystic fibrosis, currently not eligible for CTFR modulators, and links those with particular trials that are available here, a kind of a global matchmaking scheme. So we've looked further down the pipeline, and this is a really of genetic therapies, and this is a really a lot of work is going on in this area. For instance, there's Arcturus, who are developing using a lunar delivery platform for mRNA therapy. We've got 4DMT, Crystal Biotech, Splicsense, and Spirovant as well, and these are all in phase 1 or phase 2 trials. And there's an awful lot of work going on in the basic science as well. And there's a lot of investment in this area as well. So just in July, the Cystic Fibrosis Foundation committed a lot of money into Prime Medicine to develop gene editing therapy. And this is using next generation gene editing, which has potential to permanently restore CTFR function. And it can search out specific genetic consequences at the precise location, and without causing double-stranded DNA breakages, can lead to versatile, precise, and efficient gene editing without causing unwanted DNA modifications. And this technology has got wide therapeutic potential, and has been trialled in Wilson's disease and alpha-1 antitrypsin, and can be delivered via a range of platforms and could potentially lead to permanent restoration. So there's definitely a lot of work going on in this field. So Robert's already highlighted about some anti-inflammatory trials, and this is the AIRtivity trial, which is a phase 3 trial looking at neutrophilic inflammation, rates of pulmonary exacerbations. There are other trials going on as well, such as Anagram are looking at an enzyme replacement therapy, and Keogh Biotech are running a phase 1/2A trial targeting P13K, which is looking at cyclic AMP modulator to enhance cyclic AMP responses, which could promote CTFR channel opening, limit bronchoconstriction, and reduce neutrophilic inflammation as well. So what about lung infections? Well, there's been resurgence in interest in phage therapies, and these are lytic viruses which can target specific bacteria. And Biomics is, there's 5 UK sites that are recruiting to this study, and it's a nebulized phage cocktail that can penetrate the biofilm and then could potentially lead to reduction in a burden, in this case of Pseudomonas aeruginosa, which is a really key pathogen in cystic fibrosis. There's also early phase trials of Clarometrics, which is testing a monoclonal antibody biofilm disruptor, which is recruiting in a phase 1B/2A study. And again, there's a lot of work going on into investing in this, in engineering phage company. And Sniper Biome are a company which are actually pioneering the novel use of both phages and CRISPR-Cas technology to cause selective, precise, and ultra-precise killing of targeted bacteria, but also with the ability to remove the antibiotic resistance genes as well. So this may help in future in terms of reducing antibiotic resistance. And these are just in the early preclinical testing in CF, but actually they have dosed their first patient in a hematological malignancy. So again, I'd like to highlight in lung infections, finding the optimal treatment for Mycobacterium abscessus. And this is an academic trial which is pioneered by Claire Wainwright from Australia, and we have Shade Adetayo from the UK Clinical Trials Manager here. And this is a global trial. And what we have here is highlights the global need for approach whenever we have really low prevalence of disease, but we need a global platform to deliver it. And this is open in the UK, I'm really pleased to say, and we've recruited our first 2 patients here in Nottingham, and we're open in Southampton as well. And we're open in Australia, Denmark, Singapore, and we're set up in Israel, Belgium, and Taiwan. And it does highlight the need for this global clinical trials networks to deliver this. And here are some of the networks that have been involved. Now, format is recruiting for CF and also non-CF bronchiectasis. We currently only have funding in the UK for CF, but it does highlight this growing trend for co-recruitment both in CF and non-CF bronchiectasis. So when we're navigating this in terms of how we're adapting to the clinical trials delivery, there's always a balance to be had. So there is potential benefits of co-recruitment. We can test new compounds, could be tested earlier. There's a larger population to be able to test on them. It can be cost efficient and cost effective, and we can have dual recruitment at sites, and it can quicken the pipeline for delivery for people with cystic fibrosis. For each drug that we're testing, it's really important for participants' safety, and whilst it may be really applicable for some anti-infective therapies, it may not be as advisory in some anti-inflammatory trials. It's important that outcome measures are validated in cystic fibrosis, and it actually assesses the research priorities for people with cystic fibrosis. And again, we have to have enough people with CF who are actually recruited in the subgroup for meaningful licensing purposes. And central to both of these is the communication and collaboration and CF community involvement. So how are we doing at addressing these research priorities? So we've already seen from Robert about the James Lind Alliance research priority setting. There's also been a recent survey of 2,000 people by the CF Foundation, and again, they have noted the top 5 research priorities, and these are very similar to what we found in the research, James Lind Alliance research refresh. So we've talked a little bit about genetic therapies and the pipeline that will deliver them. We will hear in this conference about CF tummy tracker and Grampus CF. Anti-infectives and detecting infections. We've talked about some anti-infectives, and detecting infections is one of the hubs that Jane Davis is leading on from the Brompton, called Precision. It's important we're addressing aging in cystic fibrosis and complications, and screening for comorbidities. And at the Seattle, at the NACFC, there'll be a presentation looking at comparing FIT testing with colonoscopies for screening for colon malignancies, and there's much more work to be done in mental health as well. But integrated into all of these clinical trials in terms of how we deliver these is important of community involvement, and we have over 300 community team members from all over the UK, and they've actually helped shape over 25 research projects in this area, and it really has been, feedback from sponsors has been fantastic, and over 100 PPIE activities been held in 2024. So, to summarise, global collaboration is absolutely key for clinical trials delivery. What we do need to do is to adapt to the changing landscape. We need to look at different endpoints, how we're delivering these trials. We need to integrate the digital technologies, screening, and looking at health prevention. We need to encourage retention and growth of our teams in education, right from medical school upwards, to ensure that we're getting the right people to be engaged in cystic fibrosis moving forward. I hope I've demonstrated today there's a robust and diverse clinical trial pipeline, and obviously that community involvement is essential. Many thanks.
Thank you very much, Helen. Really sort of showing the breadth of trials that CTAP are involved in, right from those early phase trials right through to late phase, and how much has been done, but how much is really still to be done. So next I'd like to invite to the stage Dr. Laurie Smith and Professor Jim Wild from the University of Sheffield. They're going to talk to us about using novel MRI techniques to improve lung health and give us some insight from the Magnify SRC. And just a reminder, as we're hearing the talks, just to be putting your questions on the Slido poll, because we're going to have the panel question and answer after we've heard this series of talks. Thank you very much.
Thank you for the introduction. It's going to be just myself, Laurie Smith, talking today. Jim's in the room, but I'll be delivering the talk today. And thank you very much for inviting us to speak today about our work on lung MRI imaging in CF. And this is off the back of a Cystic Fibrosis Trust funded strategic research centre, which has a broad aim of how can we better utilise lung MRI for the management of people with CF. So, some disclosures from Jim and myself. So this is all about measuring lung disease and how we can measure lung disease better. And historically, we know that lung damage has been a key factor in the long-term health of people with cystic fibrosis. And in the current era of CF management, maintaining lung health is still a major priority for everybody. So how we measure that lung health is really key to maintaining that. And you're all familiar probably with spirometry. It's the gold standard for measuring lung disease. It's in clinical practice. Your patients still perform it every time they walk through the door. But yet we know it's highly insensitive to early lung disease, and it's highly insensitive to changes in lung disease. And that's predominantly because it measures the large airways resistance within the lung. And we know that CF is a condition that predominantly starts in the small airways. And so spirometry, you blow into this tube as hard as you can, it's measured at the mouth, and it all kind of bottlenecks through the largest airways, so the signals that are coming from the small airways largely are missed. And it's this region of the lung that we're particularly interested in, and this is where imaging and tests such as that was mentioned before about lung clearance index can potentially target these smallest airways. And so we're interested in a technique particularly called hyperpolarized gas MRI using inhaled xenon, and it visualizes the smallest functional changes that are available to be measured within the lung. And this is a ventilation MRI, 3D reconstruction, and what you can see here is inhaled gas within the lung during a breath hold, and you can see the patchy little changes that exist in CF. This is somebody with normal spirometry, and those little holes that you can see are the effect of airway obstruction. So this is a technique that Jim, my boss, has pioneered for a long time in the UK now, and there are centres in the US that have been doing this as well, called hyperpolarized gas xenon MRI. And this is a technique whereby you take enriched xenon, and now we can use naturally abundant xenon as well to make this cheaper. And you use this machine in the middle called a polarizer, so you entrain xenon into the polarizer. And what the polarizer does is it aligns the atoms of xenon so that it's all kind of, pointing in the same direction, so that it essentially makes it magnetic. And then when people breathe this in inside an MRI scanner during a short breath hold, some easy coaching to do this, then we obtain images of the distribution of ventilation within the lung. Essentially, the polarization massively boosts the signal of xenon, and the scanner can see it when people breathe it in. So historically, this is the slide I've always shown about what early lung damage looks like in people with CF and normal spirometry. So these are ventilation images showing the distribution of ventilation within the lung. And usually I show a middle slice through the lung because you can see the main airways and it's an intuitive image to look at. But these are 3D images of multiple slices throughout the lung. So you're getting full 3D reconstruction of the lung. And the bright white and the grey signal that you can see is gas. And the darker areas are the areas where the gas can't get to, so it's the effects of airflow obstruction. Some of those regions are completely black, so there's no ventilation getting there at all, and some of them are light grey, so it's kind of getting a little bit of ventilation during a breath hold, but not completely. And you can see from these images as well that it's not a homogeneous thing that's going on within the lung. It's not like spirometry, which gives you a reduction in FEV1, it's just one number. This is telling you regionally where in the lungs things are being affected. And the reason we want to be able to pick this up early is very clearly so that we can prevent the lungs getting worse. And these are when spirometry becomes abnormal, we're getting images that look more like this, where the areas of the lung that are not receiving ventilation become larger within the lung. They cover greater regions within the lung, and it reflects the drop in FEV1 that you see in your clinic. But what's interesting is if you look at these examples here that I've highlighted in red, hopefully that shows up, these are all people with an FEV1 of about 60%, but the images are very clearly very different. So the FEV1 is not telling you what is happening regionally within the lungs. And again, these are people with an FEV1 of 50%. So again, the FEV1 is not telling you regionally what's in the lung from a size of area perspective and kind of a frequency of ventilation problems too. So we've also been following people with CF up for a very long time now. I think some of our people have been in the studies since 2012 and are still in our studies now. And this is a nice example of somebody who had an FEV1 of 50%, and at their baseline visit for MRI, we showed that 22% of the lung is not ventilated on this image. And this is just a metric that looks at the amount of ventilation in the lung compared to the amount of the lung that isn't ventilated. And a year later, that number had gone up to 28%. So 28% of the lung had become unventilated, but the FEV1 had actually gone up slightly, if anything. And then 2 years later, again, the ventilation defect had gone up to 34%, and now the FEV1 had shown that reduction. So there's a 10% drop in FEV1 over that year period. So we think we can identify maybe when FEV1 is going to drop in the future. And that's where this slide used to stop, but now we're doing this, this follow-up trial more recently funded by the CF Trust. And so this is 6 years post that first visit. This person is on modulated therapy and has been on modulated therapy for a while, and the spirometry reflects that. We're up to FEV1 of 64% now, but the lung is still poorly ventilated, particularly if you look at that right lung, which is getting very little ventilation at all. So the number of spirometry that you are getting is not necessarily reflecting what's going on in the person's lung still. But this is not just about hyperpolarized gas MRI, this is about how we can use lung MRI in general. And one of the things that we've been able to do, particularly in our paediatric population in Sheffield, is pretty much get rid of the need for CT imaging to look for structural lung disease in CF. And these are proton MRI UTE sequence within a scanner. And this is a free breathing sequence where somebody just lies in the scanner for about 6 minutes. There's no maneuvers, that we're just imaging constantly during that 6 minutes. And we can post-process that to give you an end expiratory or an end inspiratory image that images all of the hallmarks of CF lung disease. And so locally in our clinical referrals from the Children's Hospital, they're not using CT to look for this at all anymore. And the advantage of this is we do it in the same session. So within 30 minutes, the patient has both of these images performed, functional lung imaging and structural lung imaging, so that we can start to understand maybe why some of these ventilation problems existing. And like I said, these are the UT images on the top that link to the same structural, functional abnormalities below. And we've been doing this clinically since 2016 in Sheffield, and since COVID, we've had a real uptake in the amount of clinical referrals, particularly from cystic fibrosis. And this is just a really nice example of how the local team are using our imaging. So there was a family who the child had a relatively low FEV1 in the 70s, but every time they tried to escalate treatment, there was a lot of health problems for that child. So they were reluctant to escalate treatment despite the fact that symptoms were improving and they needed to have an escalation of treatment. But they did agree to having a lung MRI to have a look at what was actually going on within the lungs. And so we performed this image, and the local clinicians showed these images to the family, and this was enough to encourage the family to try a trial of treatment. So the child had some IV antibiotics and chest physiotherapy, and we imaged them 2 weeks later. And this was the image after IV antibiotics and 2 weeks of chest physiotherapy, almost completely normalized this person's image. And this was a couple of years ago, and the clinicians still tell me that the family come in saying how glad they were to see these images and how happy they were to now have this kind of improved lung health, basically off of the back of seeing these images. Another clinical referral that we received was for a child with FEV1 of 100%-ish and asymptomatic, but the routine X-ray showed that there was some right upper lobe collapse with, and they grew some ABPA on cough swab or something. And they performed a bronchoscopy, removed the mucus, but they didn't want to repeat the CT scan that showed this problem, so they asked for a lung MRI. And we've got some xenon images and we've got some structural imaging that even though they'd had the bronchoscopy and removed the mucus, we can see that there's a functional defect still in that right upper lobe, and you can still see bronchiectatic airways filled with mucus in that right upper lobe. So having reviewed these images, they decided to do another bronchoscopy, see if they could remove more of the mucus, and then because MRI is there's no ionizing radiation, we can perform this as many times as you like. And so we performed it 2 weeks again after the bronchoscopy, and there is still a bit of a functional defect that exists in that right upper lobe, but if you look at the bronchiectatic airways on the structural imaging, you can see how successful they were this time at removing the mucus on bronchoscopy. So this is highlighting how you can use both images together. So to kind of end with, we're talking about this strategic research centre that is funded by the CF Trust, about how we can now use this further in this current era of modulated therapy. So the SRC is in collaboration with the Universities of Manchester and Nottingham, and led by ourselves at the University of Sheffield. And it's 4 projects aiming to kind of enhance the ability of lung MRI in CF. And the first is this kind of technical development, how we get more scanners to be able to do this type of imaging around the country, around Europe, for centres that want to be able to use lung MRIs, either a replacement for CT or to get functional xenon imaging in there as well. So we're working with vendors and we're working with different centres to try and enable different people to be able to do this. So this is a project led by Jim and myself, and we've got Eve, a PhD student, working on this, and she's got a poster today on some of this work. And what's really exciting at the minute as well is that we're at a stage now in the UK where we have a xenon network of different centres that are about to be able to do this, which means that we can talk about multi-centre trials using MRI as an endpoint. And if anybody wants to talk about this more, then Jim's in the room today and he'd be happy to discuss that. So Eve's going to show a poster where one of the nice things about the structural imaging that we're doing, which is different to CT, is that it's a functional image still. It's measured during tidal breathing. And that means that we can measure the change in large airways during tidal breathing. And so Eve's been looking to see whether that dynamic change that we can measure in the airways is linked to ventilation defects. And this is somebody who's had a persistent upper lobe defect for years. And we want to know, is there anything that we can see in the dynamic changes in the airways that would help us learn this? And Eve's got a poster that can go into this in more detail. The second project is just measuring people now in this current era of CF. Over time, people on modulators and people not on modulators. And these are some of the images that we're now seeing. And so even though, if you look at the adults with CF who are on modulators, they all have an increase in FEV1, they've all had an increase in quality of life, but there are still areas of the lung that are not reversing on our imaging. So this is still showing the vulnerability of the lungs to whatever comes in the future for these people. But interestingly, the children who are on modulators now, who haven't lived with CF for as long, they have almost homogeneous ventilation within their lungs. These are clinically stable. Some of the clinical referrals we see are still showing ventilation problems, but these stable children have all got nice, clean lungs now. And Demi is working on this as her PhD, and she also has a poster that goes into this in a little bit more detail. But this is an ongoing project for the next few years. The third project is led by the University of Nottingham by Andrew Prail and Laura Howells, and Dan is the PhD student delivering this. And this is all about how we communicate lung MRI findings to families, to clinicians, and to the patients themselves, because they're visually quite intuitive to look at. There may be findings on here that are a surprise to the family, and Dan's doing a lot of work developing a toolkit about how we go about communicating findings back to these families so that it's done in an appropriate manner. And again, Dan will talk about that more in his poster. And finally, the project led by Alex Horsley and Carl Whitfield at the University of Manchester is looking about how air moves through the airways so that we can learn more about inhaled therapies. So with these imaging, we have the power to image at different lung volumes, and this is a nice example of a patient who, so the middle image is the one I've been showing you, which is, it's not normal expiration, but we start the maneuver at normal expiration and they breathe in a little bit of gas. And this person has an FEV1 of 89%, but there are large areas of the lung that are not ventilating during tidal breathing. But when that person breathes in really deeply, you can get gas into areas of the lung. It's the effect of positive pressure on those airways, which shows that maybe people need to breathe in a slightly different way when they're taking their inhaled therapies. And Jonathan is a PhD student who's investigating how these images relate to lung modelling that they've been working on to try and understand this a little bit better. And I will leave it there, but just to thank the CF Trust and the CF Foundation for investing in our work, and hopefully we can get lung MRI into more centres and use this as a clinical endpoint and a trial endpoint for people with CF. Thank you.
Many thanks indeed, Laurie, really showing those images and the potential and the power there for clinical care and research. So now we're going to move on to our last talk before the refreshment break. So I'm delighted to welcome up to the stage Dr. Imogen Felton from the Royal Brompton Hospital. She's going to talk to us on answering questions on pregnancy, maternal and infant health for people with cystic fibrosis. And Imogen is from the Matriarch SRC. Welcome, Imogen.
Thank you very much indeed. I'm so grateful to Gwyneth for the invitation and to the organising committee for this chance to talk about work that we're doing and answering questions on pregnancy, maternal and infant health for people with CF. I am an adult CF physician and I work at the Brompton Hospital, and I'm one half of the PI team alongside Jane Davies, who's my paediatric counterpart, in the Matriarch CF Trust-sponsored SRC Strategic Research Centre, which is aiming to answer key questions and probably pose some more relating to reproductive goals which have so manifestly changed and expanded over the past few years in this modern CFTR therapeutic era. And the reason to focus on women's health in particular is not lost on any of us. Of course, we know that women who are trying to conceive, pregnant or breastfeeding, are excluded from the majority of drug development and interventional clinical trial design. And in addition to that, we have a vastly changing demographic with advances in CF care and therapeutics and improved survival. There are naturally more women who are going to be experiencing and living through aging and the different full now reproductive hormonal life phases and the transitions. Of course, chiefly, we're starting in focusing on pregnancy, family planning, and those transition phases around matrescence, not adolescence, but matrescence, which is from preconception all the way through to the impact of parenthood. And at the Brompton, we're a large clinical adult service looking after just over 600 adults. We've been focusing a sort of a dedicated strand of our service on aspects to do with reproductive and maternal health. And you can see down here at the bottom of the slide some of the different projects that we've been looking into. First of all, which is pregnancy driven primarily through necessity, because you can appreciate here these are registry-based trends of the rising pregnancy rates that have been recorded, so significantly changing in association with the widespread availability of ETI, elexacaftor, tezacaftor and ivacaftor here in the US in the year following availability, and again in the UK, this is UKCF registry data, doubling in pregnancy rates among women with CF, and in our own centre as well. And what's really significant, of course, is that these rates of pregnancy are remaining persistently elevated. And if that wasn't significant enough change in a phenomenon for us as clinicians and researchers, and interesting, it's really significant from a clinical perspective and from the community, from the perspective of obstetric medicine. Obstetric medicine is a relatively new medical specialty. It wasn't around when I was training 20 years ago, but it has been established in reflection of this quite worrying phenomenon, which is maternal mortality is mediated not through direct obstetric pregnancy-related complications, but more, this is data from the UK, through mismanagement or medical issues arising either because of pre-existing medical conditions and complexities in pregnancy for women with for example, CF. So we can readily appreciate that issues relating to family planning and the interplay of pregnancy and parenthood and motherhood for people with CF and their offspring really does warrant our greater attention as a whole community. So as with any good service innovation and of course research question design, we're led by our patients, and we went to our patients within our own service. and asked them what do they need in this era. We can clearly see these changing trends. This is new ground for us. So we asked them, and I'll introduce you to our first expert patient partner. This is Leah. She's a 29-year-old mother with CF, now of 2 children, the first of whom was born prior to her having started ETI therapy, the second after. And she raises some really key personal reflections with regards, I think, the unique considerations for people with CF when it comes to their reproductive health and goals.
When I was born, it was very much 30 was the life expectancy. So you always had this big number that as you were growing up, you got closer towards, and you was like, well, actually, maybe, you know, first of all, it's the guilt of, should I even be doing this? Because although this is a love and want that I want, it's then the case of, well, is that fair on a child or my partner, or, you know? But for me, it was, for me to make that solid decision of, yeah, we're going to do this, it was, is my weight, you know, my weight has to be top notch. I have to be the heaviest I've ever been. My chest has to be top notch. Like it, I think we both came to the decision of, right, well, if you can be healthy and sustain, you know, IVs, no IVs for X amount, weight is X amount, lung function is X amount, and you do that for, say, that many months, years, whatever, it was then, okay, like, let's grab the bull by the horns and, like, do this, because you're on, women anyway are on some sort of mental clock. Put CF into that, you're on, you know, it's even quicker.
So I think Leah really highlights there 2 key issues for us that we will later find out are representative, actually, of many women with CF who are increasingly wanting to pursue parenthood in this era of expanded life opportunities for them that has so manifestly been created by CFTR modulator therapy, for example. But there is a clear call there for her to say, I need and want CF-specific pregnancy guidance. What are the risks? She is clearly aware of there being certain additive risks in terms of the complexities and potentially the risks to her own CF health and that of her offspring health, in order so that she can better make these informed decisions, and for us as well as clinicians and researchers. So if I had only one slide, this would be it. Our work really is to redress this imbalance in the paucity of an evidence base to support the expanding reproductive goals of so many people with CF. And Leah is probably aware of the evidence base for the poor maternal and obstetric and neonatal outcomes historically for people with CF through pregnancy. There is a high rate of preterm birth, a high rate of gestational diabetes, and I know we're going to hear more about the impact of diabetes later on, and low birth weight. And she was also probably aware that these are relatively new drugs that we know are not really incorporated in interventional trial design. But she's aware that the 3 modulators, E, T, and I, are present and they're proven for transplacental transfer and in breast milk, albeit not associated with teratogenicity. There is increasing interest and signal data looking at the off-target impact of in utero exposure to the developing fetus, who in the vast majority of cases will be obligate heterozygotes and CF carriers, healthy offspring essentially born to mothers with CF. So understanding the potential impacts on prenatal development following maternally administered ETI is really urgently needed. And that is the context, and we're so grateful to the CF Trust for sponsoring and supporting our Strategic Research Centre grant, which is looking into the maternal, infant, reproductive and child health for people with CF. Primarily to begin with identifying what are our knowledge gaps and what is the influence, impact and interplay of CF, as well as CFTR modulators, both women on and off CFTR modulators, on their reproductive and maternal health. We'll address these research priorities, which we know through James Lind Alliance work, as well as in recent CF Foundation work. These are priority areas, in particular for women with cystic fibrosis. and we'll aim to establish a higher quality evidence base for the use of CFTR modulators during pregnancy so that we can really improve shared decision making for us as clinicians in the clinic and of course for the community. But importantly, we can develop a better infrastructure to support ongoing conduct of this essential CF maternal and infant dyad research, because that really does help inform your decisions, in particular around reproductive goals. So we've got a 5-work package streamed SRC, the first of which is actually working, and Gwyneth is involved in this, led by Siobhan Carr and David Taylor-Robinson at University Liverpool, in expanding and linking our registry data and power. Firstly, that's already happened. We've got an expanded data capture for now outcomes for women with CF and their obstetric outcomes that's going to be embedded within the UKCF registry and linking across to the UK obstetric surveillance, neonatal congenital anomalies, UK teratology information service to really improve and augment our ability to more robustly look at the systemic impacts of these pregnancies long term. We have the UK first prospective pregnancy and offspring study, which is being run out of the Brompton by CF Trust-sponsored PhD students. And this also includes a preclinical animal model data as well, with colleagues and collaborators in the University of Alabama and the CF rat model. And there's a 4th work package, which is really looking to improve our guidance materials and our resources that are available, in particular for young people with CF when they're approaching family planning decisions. And lastly, we'll be working with substrates from various biological sampling methods in our prospective pregnancy and offspring study to develop a validated assay for ETI in both maternal serum, perhaps neonatal and infant blood spot, dried blood spot, as well as breast milk. I'll just focus in the time remaining on some of our initial data. We've been recruiting in the CF MAMA study, which is a preconception all the way through to 2 years postpartum since June this year, so very early stages. But this is our protocol, and it also is really focused on quantitative outcomes, really important CF and maternal health outcomes, such as their lung function and nutritional status. But importantly, it will involve a contemporaneous, subjective and qualitative semi-structured interview work as well. So we're really relying upon fantastic research work with qualitative researchers as well. Becky Dobra is in the room. And as part of the exploratory objectives in the CF MAMA, we're also, shout out to Laurie, who's just spoken about lung MRI, but there's so much for us to understand in terms of the discovery science around the changing hemodynamics and ventilation heterogeneity that we will be seeing through pregnancy that will affect CF maternal health, and in particular around difficult pathogens and cavitatory disease and the risk of hemoptysis as well. And I think those findings will be really interesting. This is some of our initial work that's just in submission to the British Journal of Obstetrics and Gynecology, which is looking at actually the improved lung function outcomes for the majority of women who are choosing to remain on ETI through pregnancy. But what's notable is that there is still and there remains a significant preterm birth, regardless of their CFTR modulator exposure. And preterm birth is a really complex syndrome, and there are lots of hypotheses around why women with cystic fibrosis are more likely to experience preterm birth, from microbiome to the infection risk around increased pulmonary exacerbations. So more on that to come. This is another aspect of the prospective pregnancy work. This is more of the qualitative work that we're doing in 2 angles with Becky Dobra, who's analysing semi-structured interview data with a thematic analysis process, as well as we're working with graphic design master students at Central St Martin's, University Arts London, who are taking a systems mapping approach to really illustrate the complexities and the considerations for women with cystic fibrosis when it comes to understanding their reproductive goals. And this is just a lovely piece of work that was only from 2 months ago that will be part of our PPI work, reflecting back to the community in particular, the unique set of sort of experimental circumstances that they find themselves in, but how we can illustrate that and the difficulties and the burden of the emotional decision-making that they're having to make around cafeteria or ETI and pregnancy. So I'll end with a final quote from one of our subjects who's been involved in the CF Mama study, and she said, with regards reproductive health and her goals, what we need is the best clinical academic research, the best clinical trials, access to clinical trials, in particular around pregnancy, and a pipeline that means we can move from bench to bedside as quickly as possible. I couldn't put it better myself. From bench to bedside, it really is happening. The future is now, but we will, of course, I'm sure all be aware of potential future interventions of treating CF, potentially even in utero, which has been reported in several case studies, both in the US and actually across Europe, via ETI administration in a carrier mother to a CF-affected and identified fetus. So that's an area of future considerations for us. I will end with our final expert patient partner, who is Charlotte, who's recently gone through her motherhood journey, and I think her personal reflections are an appropriate point to end on here.
Through childhood, I was very lucky. I was rarely in hospital, and then I think one year it just changed, and then from there, every single year, 2 to 3 times a year, I was in hospital with a chest exacerbation. So I am very aware that cafeteria is not a cure. We all still have cystic fibrosis. We will still have problems as we age. So I really am living in the moment, and I am enjoying as much as I can get out of it at the moment. I keep saying this is almost like my second life. I'm not losing who I was, because that won't ever change, but I'm just growing as a person in this direction now. And again, I have my little family, which is all I've wanted for 5 years. So I'm definitely going to make the most of it. And there's Archer.
Thank you very much.
Welcome back to those of you joining online. So we're continuing the theme of the research goal, enabling people with CF to live longer, healthier lives. And I'd like to welcome to the stage Professor Ruth Keogh from the London School of Hygiene and Tropical Medicine. She's going to talk to us about evaluating treatment effects using UKCF registry data. Welcome, Ruth.
Thank you very much, Gwyneth, for the introduction, and thanks for the opportunity to come and talk at this meeting today. So, yes, I'm a biostatistician at the LSHTM, and I'm going to talk about some of our work on evaluating treatment effects using the registry data. Here's my disclosures. And so this is what I'm hoping to cover in this short talk. I'd like to really focus on the potential of the UK registry for studying the effects of treatments in CF, but also touch on, of course, some of the challenges that we face in doing that. And in particular, I want to say a bit about how we can establish whether we can get reliable answers about effects of treatments from registry data using this approach called trial emulation, which I will introduce. So, if we want to understand what the effect of a treatment or intervention is, then the gold standard way of doing that is, of course, through a randomised controlled trial in which people who are eligible to receive the treatment that we're interested in are randomised either to get the treatment or to some control group. And what that randomisation means is when we compare the outcomes in those two groups, we can attribute any differences to the treatment and not to any differences between the two groups, because due to the randomisation, these two groups are sort of balanced in terms of their characteristics, at least at baseline. So, if you can do a randomised trial to look at your treatment of interest, then for sure do a randomised trial. But as a person who works on observational data, I'm obliged to point out some of the limitations of trials. And these include things like strict inclusion-exclusion criteria, short-term follow-up, focus on maybe only a subset of the outcomes that we might be interested in, lack of power to look maybe at treatment effects in different subgroups of patients, and they're simply not always feasible either in terms of ethics or cost. So this is where observational data like that we find in the UKCF registry can come in and has the potential to give us some additional or complementary evidence about the effects of treatments over and above trials. So I'm sure lots of people know a lot about the CF registry in this room and online, but the UK registry collects very detailed and carefully collected information, first of all on annual data on key clinical outcomes, but also more recently we have this very nice data on the dates of starting and stopping treatments or prescriptions for treatments. Other benefits of the CF registry are that it includes nearly all of the UK CF population in there, and that it has now very long-term follow-up on a lot of individuals. So it has a lot of the ingredients that we need to look at the effects of treatment. So we know who's taking treatments and when, and we have a lot of data on the outcomes that we might be interested in. So setting aside the challenges for a moment, which I'll come back to on the next couple of slides, some of the questions that we might be able to tackle and that have to some extent been tackled using UK CF registry data that might be tricky in trials are things like, what are the effects of modulators in patient groups that have been underrepresented in trials? And we've already heard a bit about some of those groups earlier this morning. What are the long-term effects of modulators, and do their effects differ in different groups of the CF population? And aside from modulators, what are the effects of complex treatment strategies like long-term treatments used in combination? So the registry has the potential to help us get answers to some of these questions. But what are the challenges of doing that? Well, of course, a major challenge is the fact that observational data like that collected from the registry, it's not a randomised trial, it's collected data on people who are going about their everyday lives, getting treatments as they do in real life. And so we have this issue of confounding. A confounder is a characteristic of a person that makes them either more or less likely to receive a certain treatment, but also affects the outcomes that we're interested in. And it means that the types of individuals that we see in our observational data who receive a treatment, who are in some control group that we define, are imbalanced in terms of their characteristics, and that can skew our results if we look at the outcome without taking that into account. And of course, we can take into account measured confounders, and we have a lot of data on important measured confounders in the registry. So we do that at the analysis stage. So this confounding is what is often a concern in observational studies, but and rightly so. But there are also other concerns or challenges that are perhaps less appreciated sometimes. So this is just a simple diagram depicting a little bit what the registry data looks like to us. So we have individuals, these are the lines being followed over time. We have annual review data, approximately annual review data. We have periods of treatment use, and we know from this treatment start and stop data when that is. And this complex longitudinal data, it presents some challenges for doing studies of treatment effects. So we need to be able to, choose who is going to contribute information about outcomes under treatment and outcomes under control. And where do we start time? So what's the time zero for our analysis? And so we've been working on approaches to deal with some of these challenges of using complex data like this. And one particular approach that is proving popular in a lot of different areas of health research over the past few years is this idea of target trial emulation, which is described in this paper from Helen and Robbins called Using Big Data to Emulate a Target Trial When a Randomised Trial is Not Available. And they describe this sort of simple but effective approach or framework that we can use when our aim is to estimate effects of treatments using observational data. They say that we should first think of the randomised trial we would like to conduct if it were feasible, and they call that the target trial. And secondly, then go about emulating that trial using the data that we have available to us. So in this case, the UK CF registry data. So we would describe the trial we would like to conduct if we could, in terms of who would be eligible for this trial, what treatments and control group we'd be randomising them to, how long will we be following them up for, and what outcomes will we be measuring, and so on and so on. So that's our target trial, and then we look at how each element can be sort of replicated using the UKCF registry data, and any limitations in replicating some of these aspects. And this can really help us to set up, I think, or to describe very clearly and to discuss between different types of individuals, clinicians, other researchers, about really what our question is about these treatments, as well as helping us with the analysis side. This idea of trial emulation has sort of been endorsed by NICE in their real-world evidence framework. This is a diagram from their website describing that framework, where they put this target trial approach at the centre of that framework. And the UKCF registry has been highlighted as a good example of where these kind of methods can be implemented. So Gwyneth and I, along with a number of international colleagues, have put together this group, the CF Trial Emulation Network, because there's a lot of interest in using these types of approaches, not only in the UK registry, but also in other registries around the world. And you can read about a commentary on the use of these methods in our paper there. In fact, we've already, over the past few years, conducted a number of studies looking at treatment effects using registry data. I won't say more about these, but just give a few references there. But now we're kind of rewinding a little bit and saying, well, do we actually know whether the results from these studies were reliable? Were they any good? So the big question is, how do we know whether we can trust the results that we get from data like the registry about the effects of treatment, so non-randomised data? And one way of trying to get an answer to this question is through this idea of benchmarking. So suppose that we could take a real trial that has been conducted, so we know what the answer is, and we could replicate the results of that trial using data from the registry. This would provide us with some confidence that the results we would get from other studies, where we don't have a real trial that's been conducted, would be reliable. And so now the target trial is a real trial where we know the answer, and we're emulating that to see how close we can get using the registry data. This has been done in some other areas of health research. There's a big study done on this in the US, but also in a number of other areas as well. So we're now using this approach in the UKCF registry data through some funding from the NIHR, from a Research for Patient Benefit grant, which is also supplemented by some funding from the Cystic Fibrosis Trust through a Venture Innovation Award. I'm not going to say a huge amount about this project beyond what I've already said, that we're looking into this trial emulation approach. We're focusing on that in the context of antibiotic treatments and looking at replicating some existing trials using the registry data. I've just pointed out here an article on the CF Trust website where you can hear more about this study and our study protocol, and you'll also see a poster on this project from Emily Granger available in this conference, and I've listed our collaborators down here. This is a horrible slide, but just points out some of the trials that have been conducted that we're aiming to replicate. So these are trials that have looked at antibiotic treatments. I'm not going to give any results today, so watch this space for what comes out of this. Does it work? If not, why not? And can we do something? Can we figure out how we could more closely replicate the results of trials if that's what happens? If it does work, and if we can resolve any issues that we might face, this will inform further studies and guidance for others on how to do this using registry data. So let me finish there and acknowledge again funding from the NIHR, from the Cystic Fibrosis Trust, all our collaborators on this work, and of course everyone who contributes to the registry, which is central to this, people with CF and their families, people who are inputting the data, and the registry team who provide it to us for research. Thank you.
Thank you very much, Ruth. And then to complete our series of talks before moving on to the question and answer, I'd like to welcome up to the stage Professor Laura Ashley from Leeds Beckett University. She's going to talk to us about optimising cancer screening and surveillance for people with CF. Preliminary insights from qualitative interviews. Welcome, Laura.
Hi, so thank you for inviting me today. This is the first time I've been to this conference, which is exciting and simultaneously nerve-wracking. I have no conflicts, disclosures, nothing of that nature. So today I'll talk about a qualitative interview study co-funded by Barr Research UK and Cystic Fibrosis Trust, but we're only 5 months into the study, so it will be some preliminary insights from just a fraction of the data because we're still conducting interviews. So it's like a taster, not the final findings. So just some background. So as people with cystic fibrosis are living longer, it has become apparent they have a higher risk of developing bowel cancer and at an earlier age than the general population. Bowel cancer screening and surveillance can prevent bowel cancer and catch cancer earlier when it's more treatable. And so the CF Foundation have recommended that people with CF have more intensive bowel cancer screening and surveillance than the standard kind of national programme that exists, say, in the UK, and that's to have colonoscopies from 40, age 40 or 30 if you've had a transplant. And UKCF centres have begun to introduce this tailored screening, but there's very little work that has looked at people's experiences of this, and that's the kind of thing that interests me. So we wanted to talk to patients and staff about their experiences, their views, their needs around providing and engaging with this tailored bowel cancer screening and surveillance, the information, the support and the care, to hopefully provide some insights to help inform practice in this area. So we're recruiting adults with CF and clinicians from both the CF teams and the endoscopy teams from multiple centres in the UK to take part in one semi-structured interview around their experiences and perspectives, and with some focus on any challenges and needs and potential ways to address these. We will analyse using the framework method, though that is predominantly inductive coding still, to develop themes and sub-themes. And there is a strong PPI component throughout, and that includes pilot interviews and patients being involved at key points in the data analysis as well. So far, we have 3 picks on board. We hope to get a couple more, but the R&D is always a little bit crazy making, and we're nearly there with a couple more. And we have recruited and interviewed 14 people to date, 7 patients and 7 clinicians, and it's some preliminary messages, kind of insights from that data. So the first thing I thought I should probably pull out is people's awareness of this increased risk. And of course, it's not quantitative, this is qualitative, but just to highlight that a lot of the patients so far have been unaware of the increased risk and have said that being invited to the research is the first time they've been aware that they had an increased risk of bowel cancer. Somebody at the bottom there says, oh, I think it was Professor so-and-so who mentioned it, but probably because I'd read a couple of things and mentioned it to them. So they'd initiated that conversation. And then there are some things here which I think are interesting in terms of the kind of the thoughts that people have and the questions that arise when they become aware of this increased risk. So a couple of the quotes there speak to the things that people are thinking about, what underpins that risk. They're making attributions, I guess, as to why I might be at an increased risk. And somebody's saying, oh, it's probably diet. That's probably my only risk that I perceive. So they see it as tied to diet. Someone else is saying, oh, well, it must be all the medical tests and procedures or the drugs, the chemicals. So it's an insight, I guess, into their understanding of what underpins that increased risk. Somebody is saying they've Googled and it says 60% higher risk. And so people have questions inevitably about, well, the magnitude of the risk. And this person spoke for quite a while about how, in their opinion, because of the magnitude of the risk, the screening ought to be yearly. So there's some information needed around how the colonoscopy screening addresses the magnitude of the risk and what is going on there. And other things, people ask, well, is it only bowel cancer then? They wonder, are there other cancer? And, you know, if there are, what's the magnitude of the risk there? And I know that data is not easily available. And then this person's asking, well, if I did get bowel cancer, what are the treatment options? So I guess these are some insights into people's information needs and the things that go through their minds when they are aware of that increased risk. And then kind of the colonoscopy itself, people's views about this. Generally, people are receptive to this idea. And two things that seem to underpin this, well, we have a lot of tests and procedures, what is another one? And, well, if the team think that it's advisable, if my CF team recommend this, I trust them, I'll do it. So people are receptive to the idea they'll do this. They have a strong intention, or they do go ahead and do it. But they still have questions, and I guess, again, it's insight into what they think, which is important for informed decision making. Even if they take it up, arguably they should be well informed, and for a good care experience. So somebody's saying they weren't aware that anything could be treated with a colonoscopy. And I think in the general population, there is low awareness that a colonoscopy can prevent. People tend to think you're finding cancer. There is a low awareness that you can prevent it. There are concerns about infection. And patient 12 there, they had assumed that it would be performed by someone in the CF team. And so they were quite concerned that, because we asked about where, you know, if about travel. And they said, oh, not my unit, because, you know, I can't face people if, you know, they've been at that side of me. And so we said, well, it wouldn't be anyone in that team. But they don't know. And so they wondered that. And just to say that this same person said afterwards, well, straight after this, I'll be voice asking AI, can you give me the ins and outs, which is a great phrase for this, can you give me the ins and outs of colonoscopy? And I just thought I'd pull this out because it is topical. We asked, and I did wonder, should I include this quote here, but we said, do you ever look at any particular websites, CF Trust, any others? And they say, I did, before AI. And, you know, it fascinates me, the use of AI by patients to answer their questions, as well as even in a therapeutic fashion. But, you know, he's saying it's helpful, and it remembers I've got CF, so it's personalised, it's remembering things, and therefore people see it as being fairly reliable. He said in a different part that it's like speaking to the most intelligent person on the planet. And he felt that it gave him more help than he'd had from a healthcare professional. So I guess, you know, in this is the way it is now. And so I just thought that was very interesting about using AI to answer his questions. And another thing, I guess, just to flag, people feel, and this won't be a surprise, I'm sure, they have huge amount of trust in the CF teams. they feel very well cared for and quite safety netted. But I guess, so this person, patient 8, is saying they really look after me. You know, I get whatever they think I need. But I guess just a flip of that is, if they don't mention something, that must be because it's not important. And I guess that just speaks to a couple of other studies. So there are 3 studies we're doing. A different one funded by NIHR is all cancers, and there's cervical screening covered in that. And this is just a couple of quotes from staff saying that we don't really mention cervical or breast screening, but it, you know, put together with this idea that if it's mentioned, it's important, therefore perhaps if it isn't mentioned, not that important to me. And this person is saying about how they put their smear off for 3 years, even knowing how important it was. And then the quote at the end, I'm pretty sure if Dr. So-and-so said jump off a mountain, I probably would. So I guess that's the power that the teams have, you know, to advise something, to recommend something. And then just to highlight the final study, this grew out of the other 2. In doing the PPI for the studies about screening, we were talking to people that had developed cancer, and they told us about those cancer experiences. We didn't ask, but you know, people like to share their stories. And then we felt we need to capture this and do a study on the cancer experiences. And so we're doing this study, which really highlights the impact that having CF has on your cancer treatment decision making, and undergoing that is a massively complicating factor. But then what happens with the cancer, you know, impacts your CF care, and those interviews have been quite touching. You know, they're a hard read actually, and we only have 4 people in that study to date, but we hope to get 10 because obviously it's a small group. So thank you for listening.